Hasn't the time come for Canada to provide equitable access to health services for all Canadians? The patient care issue being presented is Aboriginal health inequities.
Aboriginal health inequities requires attention from political leaders, nursing leaders, and those with the ability to promote positive change.
As a result of deep-rooted historical policies, Aboriginal communities have consistently been neglected in the provision of basic healthcare services.
Considering health inequities are differences in health outcomes that are preventable and unjust, nursing leaders have a moral imperative to advocate for equitable access to healthcare services for Aboriginal Canadians. With the aim of assimilating Indigenous children into Canadian society, residential schools were inadequately funded, resulting in inadequate resources such as food, clothing, and healthcare for Aboriginal children. As a result of these conditions, many children and generations to come experience significant psychological distress, leading to a host of health issues. For instance, today, First Nations Canadians are 3 times more likely to commit suicide compared to non-Indigenous Canadians. But why is this the case? If we zoom out and take a closer look, we can see that societal factors play a larger role in this dilemma. Aboriginal patients are at a social disadvantage as they are marginalized from the rest of society. As a result, they lack adequate access to vital and emergent healthcare resources, which is oftentimes the driving force for the promotion of further health inequities.
So what is the solution?
Aboriginal health disparities requires political action, as such disparities are driven by government legislation. Generally speaking, healthcare is regulated at the provincial level. However, for Aboriginal populations, socio-political barriers to healthcare services include vaguely described legislation. For instance, the Constitution Act of 1867 establishes that status Indians fall under federal jurisdiction, while Métis and registered Indians off reserve fall under provincial legislation. On the surface, these legislations are straightforward. However, the problem lies when individuals are caught in the middle, those individuals who do not qualify for Indian status, thereby creating challenges in accessing healthcare services. Consider the case of Jordan's principle, the case of a young patient who spent 2 years in hospital while the federal government and Manitoba government argued in court over payment for home health care. Jordan's principle was then established, mandating when a jurisdiction-related conflict occurred, the government of first contact was responsible for funding, and disputes would be resolved at a later time. While this legislation sought to resolve potential health inequities, the legislation actually created more harm. The definition used to describe the principle was loosely defined, thereby excluding many children. For instance, under the principle, children had to have had complex medical needs with multiple healthcare providers. Hence, weak Aboriginal health policies that are complex in nature, excluding Aboriginal communities, remains a primary barrier in reaching health equity. So who are the key stakeholders involved? Aboriginal patients are key stakeholders as they directly are influenced by health disparities. Aboriginal patients in their communities are the main parties who experience health disparities like inadequate access to healthcare and higher burden of disease compared to the general population. Similarly, healthcare workers such as nurses, doctors, and allied health are key stakeholders as they have direct knowledge and experience of the health disparities Aboriginal patients experience based on their own clinical experience. Healthcare workers are unique stakeholders as they bring their expert knowledge on the severity of health inequities to the table. Indigenous leaders are also key stakeholders as they are the representative voice for their communities. They are the strong leaders who continue to advocate for Aboriginal rights, such as equitable access to healthcare services. Governments, such as the federal government, are key stakeholders as they're responsible for funding First Nation communities. Provincial governments are also key stakeholders as they're responsible for funding Métis, registered Indians living off reserves, and non-registered Indians and Inuit living outside territories. Unfortunately, at times, either government cannot agree on a consensus regarding which government is responsible for funding. Hence, the government is a key player as they have the power to promote or block healthcare funding and reform.
Following an upstream approach at the macro level, the solution to decreasing the gap in health inequities amongst Aboriginal patients is rooted in strong health policy. As such, there is a need for Indigenous healthcare reform in collaboration with both provincial and federal healthcare systems in consultation with Indigenous communities. Jurisdictional gray areas for healthcare accountability between governments is simply not acceptable as it leads to unjust health outcomes for Aboriginal patients, as evident through Jordan's principle. Rather, there is a need for a clear legislation which includes provisions listed from the United Nations Declarations of Rights of Indigenous People, which the government signed but failed to implement. Article 24 of the document states Indigenous people have the right to access health services without discrimination. Potential mechanisms to create change would include the use of a policy change cycle, which first begins by acknowledging the problem. While it's understood there's a clear issue, the fundamental next step is to create meaningful action. Actions such as forming proposals with fair negotiation with Aboriginal leaders, while using a health equity lens. Finally, change will require a transformational political leader, one who envisions a Canadian society that provides equitable access to health services for all Canadians, including Indigenous populations. Change will also require government leaders to respond to the call of healthcare reform. This includes having specific health legislation which accommodates for the needs of Indigenous communities. Legislation should address social and healthcare needs, child welfare, and the training of more healthcare professionals. The creation of an explicit health policy framework will prevent any jurisdictional conflicts, thus ensuring equitable access. Organizational level, systemic racism and bias is the root cause of health inequities for Indigenous patients. Most patients are often stereotyped as difficult or patients who simply use substances. Most Indigenous Canadians have experienced significant intergenerational trauma and have resorted to unhealthy coping mechanisms to deal with decades of psychological pain. When such biases are introduced in the healthcare system, Aboriginal patients do not receive the same standard of care. Consider the case of Brian Sinclair, the Aboriginal gentleman who spent over 24 hours in a Canadian emergency department with no medical assessment. He was assumed to be intoxicated or sleeping it off. He was later found deceased for 7 hours while waiting to be seen. He was in obvious medical distress and with no medical interventions being given. Meso-level solutions include interdisciplinary teams who include Aboriginal staff who can help with the development of culturally appropriate plans of care. Using such an approach promotes increased accessibility in healthcare services as patients are able to navigate the healthcare system without fear of bias or discrimination. Finally, at the micro level, healthcare professionals are in a unique position to use their expert knowledge and voice to advocate for Aboriginal patients. Following an upstream approach involves government policies. The collection of data at the population level will be key in evaluating effectiveness of proposed strategies. Comprehensive data on key population indicators, such as infant mortality, maternal mortality, and morbidity, are essential to compare health status with the general population. Such data should be measured, reassessed at scheduled intervals to assess for improvement in health disparities. Successful health promotion strategies can ensure the federal government increases funding to Aboriginal communities. At the organizational level, methods to evaluate efficacy of meso-level strategies include collection of data on health outcomes based on race, gender, and socioeconomic status. Hospitals should also stratify data on quality measures reported to regulatory bodies such as Accreditation Canada, but should also report those measures based on race and gender. This will allow independent parties to assess if Aboriginal patients are indeed receiving the standard of care as appropriate at the organization or hospital level. Similarly, such measures should be reassessed on an ongoing basis to analyze if hospital policies are effective in decreasing health inequities for Aboriginal patients. Organizations should then use data collected for quality improvement initiatives. Researchers should then liaise with hospitals by using stratified data to determine potential disparities and create follow-up methods which are culturally informed in order to monitor the efficacy of ongoing health promotion strategies. As mentioned by the Honorable Murray Sinclair, education is what got us into this mess, and education will get us out.